afternoon, everyone, and welcome back to Grand Round. And to have me for one more time in this introduction, so I get to be all again. And today it's my pleasure to introduce Dr. Nicole Lohr. She's a Wisconsin native who did all of her training at the Medical College of Wisconsin. She had both of her MD and PhD degrees from there. She liked it so much she decided to stay on to complete both the residency and fellowship and really start to champion her independent career there. Where she did quite a bit of work on both developing some thinking programs as well as establishing both her research aspect, which we'll hear today, and very clinical applications. So really the true definition of imaging scientist, applying what she's learning. So we were fortunate to find out to recruit her just a little under 10 months ago. So we've got many of people on campus. And now she is a professor and director of both the division of cardiovascular disease and the director of our comprehensive cardiovascular disease. We've covered several different areas, but most relevant to today's talk is her long-standing nitric oxide signaling. And this really, as we'll hear in a moment, novel induction microbiome. So I'm just very curious, and I'm really excited to see how that works. And her work's been funded by both the NIH and VA, and she has over 50 publications, both primary and editorial, every kind of the translation research. In addition to both these scientific and clinical roles, she's an outstanding mentor and teacher, having implemented several programs at Medical College of Wisconsin, which she's really brought into her new roles here. And I've had the fortune of working with her through the system, really just seeing her leadership and enthusiasm she's bringing to the to kind of amplify our cardiovascular research. So I look forward to seeing what the years to come are going to do. So that said, I don't want to take up any more of her time because I want to hear about this light and Knox. And please join me in welcoming Dr. Lohr as she tells us about red light modulation of vascular function. No is the way.
Thank you. Can all of you hear me okay? I'm a walker, so I had to have a mic. So I have to say it has been just an honor and privilege to give this Grand Rounds, because to me as an NO investigator, this is like coming to the Mecca. And knowing, the great people like Jack Lancaster and Rakesh and Victor. And in fact, one of my dear friends and collaborators in Wisconsin and how I got into this field is Neil Hogg, who was a trainee of Victor. And so, I'm going to start with the problem, and I guess this doesn't advance, so that's okay. We're good. I can do all these things, but not operate the remote mic. All right. Well, I'm going to be contained a little bit, I guess, around the podium, but my area, so I'm a cardiologist by training, but I've always been interested from a basic science level and a physiological level of vascular function. And really looking at, originally a lot of my work was in the coronary circulation. And now, honestly, I feel it's an opportunity for me here in Alabama to talk about peripheral artery disease. I think as cardiologists and as physicians, we're always focused on the heart, right? If I have an MI, I could die. But the reality is peripheral artery disease is a lesser known cardiovascular disease, but really speaks to a much more severe form of vascular dysfunction. And so, 8 to 10 million Americans are affected by this. It gets more prevalent as we grow older. As I said, it's a more severe form of vascular dysfunction with 3 to 6, a diagnosis of Ph.D. makes you more likely to die of a stroke or MI than someone who doesn't. And despite all of the progress we've made in the coronary circulation, we've done an abysmal job with peripheral artery disease. And I think you can see that in your own communities, especially when we think about the number of amputations. And there has to be like a better way to, solve this problem and crack this nut. And, having now been here, especially in the South and in the southern part of the state, we have a lot of work to do. And I think, honestly, when we think of the peripheral circulation, we think of large conduit vessels that over time develop plaque again, from the same standard cardiovascular risks of atherosclerosis, hypertension, and diabetes. And so if you look at this slide, you know, what becomes apparent is like, well, maybe if I just fix this and I remove the blockage, then things will get better. And we know, okay, if I have an acute MI, I open up the obstruction, the patient gets better. But this is really a more chronic and insidious process. And while we can open the inflow here in these large conduit vessels, we oftentimes still don't marginally affect their quality of life. And that's because these people, if you step back, who have a diagnosis of peripheral artery disease, they also have microvascular dysfunction, you know, and in our coronary community, we're starting to embrace microvascular function and dysfunction a little bit better, and I think we can do the same here. And so we know that there's a significant association in patients with peripheral artery disease between an abnormal ankle brachial indices, which is the way we can diagnose PAD, and reduced flow-mediated dilation. And so flow triggers the endothelium to release nitric oxide, which causes vasodilation. And so this is basically, you know, what you see here. We can basically inflate a cuff. We can measure the flow across the brachial artery, and we can constrict this, and then you'll see a reactive hyperemic response, which is going to cause more flow across the brachial artery, which should elicit dilation. And if you look at a healthy subject, we can expect about a 5% change in the flow-mediated dilation. And in those patients with PAD, it doesn't matter if they have diabetes or not, but it's significantly reduced, you know, maybe to 30 or 40% of what a normal person is. And so looking at this, that's telling us that the nitric oxide and the vasodilatory capacity of that vessel is impaired. And that may explain why, in large part, when we do put stents in, or if we do perform bypasses to those peripheral limbs, that we still have patients who have persisting symptoms. And the other thing to note is that when we do physiological maneuvers or treatments of patients, like putting them into supervised exercise programs, we actually do see improvements in flow-mediated dilation, and that also aligns with symptoms. And so there's a great opportunity for us to start to think about how can we improve endothelial function in this very dysfunctional population. Okay, so why do we care? What are some of the mechanisms that we're going to talk about today? Well, I kind of alluded to it a little bit. You know, when we want to think of nitric oxide, the first thing that comes to mind is the enzyme that produces nitric oxide, and the nitric oxide synthases, which convert L-arginine to L-citrulline. Tetrahydrobiopterin is a cofactor of this enzyme, and it produces nitric oxide. This NO diffuses from the endothelium into the smooth muscle cell, binds the soluble guanylate cyclase, which is a heme molecule, and I want you to kind of put that in your brain. And it will then be simulated to convert GTP to cyclic GMP, which then triggers vasodilation. That's under healthy conditions. Now, if I'm smoking, I'm not, you know, I will say I'm getting used to the Southern diet. I'm trying to oppose it. I have a hard time smelling fried chicken when I walk into a hospital. It's a little bit different, but right, we're spending a lifetime of being insulted by a lot of pro-oxidative threats, I'll call them. High blood sugar, you know, high cholesterol, all these inflammatory responses. And the endpoint of inflammation is oxidative stress. And so in situations in which oxidative stress is high, often in disease, we see that the nitric oxide synthase enzyme doesn't work very well. And that major source of nitric oxide within the endothelial cell is now becoming impaired. It's impaired in a couple of ways. One is that we know that eNOS transcripts and expression of the eNOS enzyme in and of itself is reduced. And then secondly, we also can see an uncoupling of it. So this tetrahydrobiopterin molecule is now no longer contributing to the healthy production of NO, but actually of superoxide and reactive oxygen species. Superoxide doesn't like to hang around for long. I'm sure many of you know that. It can either bind more NO, create peroxynitrite, which in and of itself effectively scavenges NO, or it can also, like I said, again, cause transcript to go down. So unfortunately, unhealthy feedback loop. So thankfully, our bodies are not designed to just accept one method or one path. And so what I find very interesting about the body is if we think about the NOS-dependent pathway as, you know, an oxidative change from arginine to NO, we have a reduction pathway. So there truly is a yin and a yang. And it was Mark Gladwin who really elegantly started a series of experiments that really looked at what are the backup systems essentially within our bodies in order to be able to generate NO. And what's interesting about this is this is, as I said, eNOS is a very oxygen dependent process. The generation of the reduction of nitrite to NO is a reductive process. And it turns out that this is actually something that can be leveraged during ischemia. So hemoglobin and myoglobin have iron, which has a high affinity for binding NO. So in normal conditions, if I have NO and I have deoxyhemoglobin, that NO is going to bind with incredible affinity. We call it recombinant gemination. Nitrite can actually be, once it interacts with deoxyhemoglobin, can be reduced. And so deoxyhemoglobin and deoxymyoglobin have what we call nitrite reductase activity. And so what happens is nitrite is reduced to NO, which then can be essentially auto-captured in the second, you know, to iron nitrosyl hemoglobin. So in a very elegant way, within our blood and within our muscle, we have this kind of this store, so to speak, of nitric oxide. And so the question became, you know, can we do something to leverage that? Other potential pools of nitric oxide are through S-nitrosothiols. And I am not going to stand up here and by any means try to pawn myself off as a chemist or a biophysicist. As you see, I probably should drink some water. I kind of muddled my way through the chemistry of deoxyhemoglobin and myoglobin. But essentially, we have thiols and proteins with thiol modifications everywhere in our cells, okay? And it isn't quite as simple as saying, okay, I have this thiol and I'm going to just attach NO, kind of like in the prior situation with hemoglobin. Hemoglobin, that iron, it sees that NO and man, it comes together. But not so with nitrosothiols. And so potential ways in which we can generate S-nitrosothiols is through the auto-oxidation of NO intermediates, N2O3. They generate thiol radicals, and they use iron and copper to undergo enzyme catalytic enzymatic formation of a thiol to an S-nitrosothiol. These compounds, though, are very sensitive to light. And it's been well publicized that UV-vis light actually can degrade nitrosothiols. Heat can do it as well as ascorbate and glutathione. So if we could again take this source of, I would say, stable-ish NO and create NO that's available for use, that would be another potential mechanism of how we can improve the NO state within our body. So let's talk about light. I'm already 15 minutes into this. You guys are probably already like, when is she going to talk about light? So the best part of being a scientist is when you think you have the answer, when you think you can look at something and immediately at the surface say, yeah, that's not going to work, and you're proven wrong. And that's what this whole journey with red light has been. And so I was in the ABIM research pathway. I had just finished my intern year. I was going back into the lab to work with one of the members of my thesis committee at the time. And I had this grand idea. I had sketched out exactly what I wanted to study for my lifetime of research. And he goes, I'm interested in red light. And I'm like, I don't care. I just told you what I wanted to do, right? You know, and he's like, well, guess what? You're the trainee and I'm really interested in this. And I'm like, well, why are you interested in it? And he had a couple of papers that were brought to him that talked about light in the far red range. So we're not talking about infrared lights. We're not talking about heat lamps. We're not talking about near infrared light. We're talking about red light that you can actually see. And that spectrum is really between like 630 and I would say 700. It starts to get orange beyond that. And what's interesting and novel about red light is it's actually, there's a very narrow optical tissue window. And so, you know, you can say, okay, well, you said UV and like green blue light can maybe reduce an S-nitrosothiols and release NO. But the optical penetration of that is like less than, you know, it's like a millimeter, right? So from using it as a biological tool or a therapy would be difficult. But the optical tissue window, and I had a graduate student at Marquette University, we did a lot of phantom modeling of this, is there's significant absorption within 1 to 2 centimeters that can be, you know, it's a decent amount of penetration. And the other thing that's important is right, you know, if you think about a heat lamp or, you know, you'll have your, you know, you'll go to a restaurant and sometimes there's like a reddish light like on your food trying to keep it warm. It's because water and energy, that water absorbs energy and energy heats. And so what we don't want to do is we don't want to heat tissue, right? That's not our goal here. And so within this range, what we've done is we've reduced the amount of heat production and we optimize the penetration. And so people use this, and I'm sure you've seen people want to grow hair, and you can go online. You can give it to athletes. You can have wound healing. You can make your dermatologist love it, right? You know, and so we've seen opportunities in which people are using this technology, but they don't know why they're using this technology and they don't know how it actually works. And so, so I said, okay, fine, I'll do a series of experiments. I'll write a paper and I'll move on with my life, and I'm going to do something, you know, more grand and more special. And here I am, like 15 years later, still trying to figure it all out. And so what happened is that we did a series of ischemic high limb experiments in rabbits. And the long and short of it is a very simple experiment would be to inhibit NOS. And if you inhibit NOS, you'll inhibit angiogenesis. It's a pretty well, you know, thought out hypothesis. Well, when I gave NOS to animals and I exposed red light, I did not have a reduction in collateral growth. And so that really is where I started to look for these alternative sources. So we did a very simple experiment in an ozone chemiluminescent chamber in which we turned the light on in the presence of buffer. There's no signal. We put 20 micromolars of HBNO into the ozone chemiluminescent chamber, and we turned the light on, and we could see a peak, which was indicative of a detection of NO. As soon as we turned the light off, we could see a resumption back to baseline, and we could repeat this over and over again. We found this effect to be reproducible and somewhat dependent on the intensity of energy delivery. And we were also able to repeat this with purified myoglobin as well. The story with S-nitrosothiols also speaks to the specificity of the effects that we're seeing. So the best part of doing something novel and the worst part of doing something novel is the fact that nobody believes you, and they think that you're somehow like it's a phenomenon and there's errors. And so so a lot of this was like, well, this is just general, it's not specific. And so we were able to show with different versions of S-nitrosothiols and non-heme iron iron complexes is that if you looked at a small molecule S-nitrosothiols like GSNO or SNAP, you could see there were pretty significant increases that were also, again, fluence dependent with GSNO and SNAP at 670. And you can see the signals are quite a bit reduced in relation to each other. DNICs also were able to perform similarly. And so if we look at this and we quantify the nitric oxide in picomoles, what you see is with SNAP, you see with an increasing amount of energy, you see a significant increase in NO, and that's at 670. This is 740 and this is 830. And you can see the orders of magnitude difference that we're dealing with. And so there really is specificity to some extent, or maybe efficiency is the better word to use. And why what we see here is why we've kind of said, no, we're not going to look at other wavelengths of light. The differences between SNAP and GSNO or DNICs, I think, are largely steric related to the chemistry and how the light interacts. But regardless, we felt pretty confident that we were going to stick with the 670 nanometer wavelength. So again, everybody thinks that what you're doing is just some sort of phenomenon, and they're like, well, this is just heat. We did a series of experiments kind of trying to contain and standardize everything with an ozone chemiluminescent chamber and then measure. And we could see that you could go up to very high intensities of energy, and there really was less than a 1 centigrade change. We'll get into the animal experiments and the physiology later, but to be honest with you, I'm really not operating more than 10 or 15 joules. So, I mean, despite high levels of energy, we're only seeing a 1 degree centigrade change. If I look at the stability of SNAP without light and just look at, different temperature changes, I can see that SNAP does not degrade with a change in temperature. Nor have we seen significant changes in NO production or degradation from GSNO. And so if we quantify all of these things, if you look at changes in temperature and the amount of dilation in vessels, we also see that changing a pressurized vessel from 37 degrees to 41 degrees in the absence of light does nothing to change. However, if we look at 670 light, we see significant vasodilation. So again, all speaking to the care that went into making sure that what we were studying was not a phenomenon. So that's the chemistry of it in a very non-chemist's perspective. So I'm a little bit intimidated by all of you because I'm like, please don't ask me any chemical questions. But what I can do is talk to you about what I love to do, which is looking at actually the physiology of what we're studying here. And so we made a very conscious decision to be able to say, okay, let's pull this into an ex vivo model and let's carefully start to untangle some of the mechanisms behind this. And so the first set of experiments that we did was really to take facial arteries from mice, and we pressurized them and then exposed them to different wavelengths of light. So kind of trying to mimic what we saw chemically, can we see it physiologically? And what we saw was actually really fairly consistent. We talked about orders of magnitude difference of NO production between the different wavelengths, but here you can see, I would say pretty elegantly, it again says 670 is really the optimal wavelength by which red light causes vasodilation. So now that we have this ex vivo model, now the fun begins, I would say. So, okay, well, is this going to behave the same way as these infamous, hind limb ischemia experiments that I performed? And so the first set of experiments was to look at, okay, what does light do to vasodilation, and is it NO dependent? Is it NOS dependent? And so here we did the same pressure myography again of mouse vessels. And we shined for 5 minutes, and then we we turned off the light for 10 minutes and we stimulated again. And you could see vasodilation whenever the light's on. We're excited. We go, okay, let's use an L name. Same thing. Not, maybe you could argue there's some blunting here, and when we intend to look at that mechanism, I just haven't yet. And then the final thing we did is, okay, is it NO dependent? And so we used an NO scavenger, carboxy-PTIO. And if you use the NO scavenger, you are able to abolish the effects. So we're pretty confident that it's NO. It's not really NOS dependent, and it's pretty reproducible. I send this in, right? I'm all excited. I got a paper. And the reviewers reject the paper, as reviewers always do. And they reject the paper and they say, this is a phenomenon, your vessels are damaged. This isn't what you're seeing here in this dark period. If it was really a truly physiologically reactive vessel, it will go right back down to baseline. And I'm like, fools, right? I'm like, just very typical, right? Like we hate reviewers, right? We love reviewers, we hate reviewers. So I say to my technician and lab manager, I said, you know what? Just give some U46619 or give a vasoconstrictor and endothelin 1 and just show that the vessel constricts and we can move on. And that's the next fun part of the story that I'll get to, because the moral of that story is, again, you expect to see something happen and it doesn't. And so because he was a great lab manager and friend, he does what I tell him. It doesn't vasoconstrict, and he thinks to himself, why wouldn't it vasoconstrict? And it's like, well, maybe this is because it's ex vivo. So he removes the buffer with the same vessel, puts fresh PSS in, gives endothelin, and it dilates, or it constricts. So, and that'll be the next set of experiments that we talk about. But again, here we were able to reproduce that this is not NOS related. We used eNOS knockout animals and we saw similar effects. But what we did know is that it was endothelial dependent, which made us think a little bit outside of our first hypothesis, where we were really focused on heme moieties, because hemoglobin and myoglobin are not in the endothelium. And if you take a little air bubble and you push it through a microvessel, you can shear off the endothelium. And so in a denuded vessel, we could not see effects of light. We did know ODQ could abolish the effects. So we knew the typical NO from the endothelial cell to smooth muscle cell pathway was important. And so we started to look at S-nitrosothiols, and that seemed to make more sense if we're thinking about focusing on the endothelium. And so we did very similar experiments to what I showed you before with ozone chemiluminescence. And we could take from the bath solution, we could take that, I said, there must be a vasodilator. And so we put the bath solution into ozone chemiluminescent chamber, and we were able to measure a significant amount of triiodide dependent chemiluminescence. And so this NO precursor was somewhere in the order of 4 to 5 nanomolar. Because because it's kind of a mix, we wanted to know what the relative contribution of S-nitrosothiols was. And so if you give mercuric chloride and you treat that solution, that's going to basically kind of eliminate your S-nitrosothiols. And so the S-nitrosothiol population, for lack of a better word, or species contribution to the bath solution was pretty significant, about 75% of what we saw. Again, we wanted to make sure that what we were seeing was real. And so we denuded control vessels, which didn't have light, and those that had light. And denuded vessels did not seem to be able to, we couldn't quantify any NO precursors by ozone chemiluminescence. Again, to kind of make sure that S-nitrosothiols were an important physiological contributor, what we did was we again did our standard light experiment, and we also pre-treated the vessel with ascorbate. So we did our very best in very high concentrations to kind of essentially eliminate or scavenge as much S-nitrosothiols as we could. And there again, we saw an attenuation of vasodilation with light. And we also saw, again, we were using 15 millimolar ascorbate, significant attenuation of the ozone chemiluminescent signal. So we became pretty excited that we had a vasodilator that was relatively stable and had the characteristics of an S-nitrosothiol. All right, so how stable is it? So we decided to really characterize this in the following manner. Well, if light produces this vasodilator, and we think this vasodilator is an S-nitrosothiol, then I should be able to take that bath solution and give it to an unexposed vessel, and it should dilate. And so we did that. We pressurized the vessel. We had no light. We took that bath. We transferred it. Nothing happens. All right, so now we give light. And those original experiments were like 5 minutes. We've now increased it to 10. We can see more significant vasodilation, and we take half of this bath solution and we add it, and we can see stimulation of vasodilation in this second vessel. So we're getting excited. All right, well, how much of this is dependent of NO? Okay, so we have vessel 2 waiting for bath from vessel 1, but within there we have CPTIO. So if there's any NO that's in that bath that's going to be produced or transferred over, we're going to try to scavenge it. And so you can see that a lot of the vasodilatory action was really NO dependent based on the carboxy-PTIO. And then again, just to confirm what we saw chemically, if I denude a vessel, can I still transfer the effect? And the answer is no. We have been able to show that if we hold on to this vessel bath for 30 minutes at 37 degrees, and then we transfer it, that we're able to, even at 30 minutes, we're able to stimulate robust vasodilation, which also said, okay, well, NO is fleeting, right? We know it's a gaseous molecule. We know some of these substances are also going to be very prone to degradation. So why is it that it's so stable? And so that really is what kind of has led us down the next kind of series of experiments. Because the reality is we do see these effects, not just in pressurized vessels, but we also see them in actual animals. And so we published this data looking at microcirculatory flow using laser Doppler imaging. And we looked at different intensities of light for different durations to try to kind of optimize the dose of light. And then we took the plasma from the animals on sacrifice, and we were going to quantify for S-nitrosothiols. But what you can see here is that even if I shine light, I can still see significant dilation within the microcirculation for significantly, at least for 10 minutes. By 30, the effect is kind of reduced. So there does seem to be a stability in the effect of light, which makes it a lot easier to deliver for treatments. I kind of gave you a little bit of a teaser here. I said, yep, and then we looked for to try to measure plasma S-nitrosothiol levels. And you can see that these S-nitrosothiol can be significantly measured from the plasma, which I can say was not easy. And it became a little bit more difficult and variable. So we can at least see whatever this is triggering an effect, up to, 10 minutes later, but by 5 minutes and 10 minutes, we're pretty much back down to baseline. So that's another area of exploration that I don't quite have the answers for today, but definitely interested in looking. We don't see much of an effect or a reduction in the amount of S-nitrosothiol content in like the muscle or the tissue of the animals that were exposed. So we've started to look at trying to employ models of subacute ischemia. This is part of our NIH award, where we developed very micro amyloid constrictors to place on the femoral arteries of mice. And let me tell you, Brian Lindemer, who was my tech and lab manager, who was with me from day one, is a goat, because I said, hey, can you do this? And he goes, I'll figure it out. And pretty soon, like he's manufacturing like amyloid recipes and using Dremels under to put on these little amyloids. Because what we really wanted to do was we wanted to be able to study peripheral artery disease more similarly to what a patient might experience. And acute hind limb ischemia is just not reflective of really the chronic inflammation and ischemia that patients undergo. And so we wanted to see if we could kind of enhance some of these effects, as I talked to you about, under ischemia, we should see improvements in myoglobin and hemoglobin generating NO. And so a lot of the amyloid constrictor experiments that we did really showed, I'm going to have you focus on this one right here, is really that, throughout the 14 days of the amyloid constriction, we do see significant increases in dilation. And so it's kind of the precursor to what a therapy might look like for chronic ischemia. So we have kind of a stable NO source. It looks like a S-nitrosothiols. How could this possibly be working? And this is some of the VA merit award work that we've been doing. And the idea is that, okay, if this is an endothelial cell, we know we have mitochondria. This is my cartoon. Sorry, not the best artist. But there seems to be that there should be S-nitrosothiols like all within this endothelial cell, and there must be some way of packaging them and getting them out of the cell. And so we talked about calcium dependency in transport and vesicles, and whether or not there's a role for reactive oxygen species in this process. And so what we saw in a very crude way at first was, okay, if I take that bath solution that seems to be paying dividends, let's keep kind of trying to mine that a little bit more. We can see that there is an increase in particle concentration. The size doesn't really change. These are rather, I will say, large for some of the exosomes and extracellular vesicles. And if we try to look at these with fluorescent antibodies for FM595, which kind of looks at membranes, von Willebrand factor would be specific for endothelial cells. And if you look at co-localization, just literally under a microscope and trying to count and then look at fluorescence, we can see that there might be something there. Cis-NO antibody is like the only antibody that really looks at S-nitrosothiols, and it's a really dirty antibody. And so it's not a great way of trying to visualize this. But what we did again was, we kind of pelleted down or tried to isolate these extracellular vesicles before and after light. And the only way that we could really have any confidence in the cis-NO antibody was to also have a set that was treated with mercuric chloride. And if you recall back, I said, if you treat with mercuric chloride, it'll deplete the S-nitrosothiols. And so what we saw is, if we looked just from a fluorescence level, there was a significant increase with light. Okay, well, how much of this is contributed by S-nitrosothiols? Well, you can see you can actually deplete the S-nitrosothiols and see a reduction, and that's what we would have expected. So again, I would say not maybe the most sophisticated way of doing it, but it was something that at least allowed us to kind of continue down the pathway. So, okay, if something's leaving a cell, then somewhere else, so something's increasing, something should be decreasing within the cell. And so again, we use that same cis-NO antibody to look at endothelial cells and fluorescence intensity, again, treating with light and mercuric chloride. If we take cells and we treat those cells with light, a purified culture, we can see again increases in SNOs. So we felt pretty confident that we had all the pieces together to suggest that, hey, these SNOs are probably being transported through, you know, the intracellular vesicular transport pathway. So we've looked at doing this with fluorescence. We looked at CD63, which is part of the classic transport pathway. Again, looking for that within, do we see light upregulating, you know, within vesicles, which is part of, this is part of the fluid that we characterized, and then this is part of the cells, and we can see CD63 is upregulated. So the light is stimulating some transport process. Again, we wanted to kind of now start to be a little bit more sophisticated and start to use flow cytometry. And you can see that within light-treated endothelial cells, we were able to sort out for CD63 positive exosomes. So it's also interesting about science is it's like, well, you're like, geez, it kind of seems like there's this vesicle of S-nitrosothiols that are sitting in the, that's kind of unique. And then you realize it really isn't all that unique, or maybe somebody else way more smarter than you thought about it, which is absolutely what happened. So Louis Ignarro, one of the great Nobel laureates of NO research, had published in Hypertension in 1990 that he thought, hey, you know what, this is kind of an interesting concept. And I looked for any paper to link it back, and there was really nothing, you know. So I think you really, you know, but when you get a Nobel Prize, you can just like write to Hypertension, and then people publish this, right? You know, which is really super cool because he was, I think he was right. So so here's our endothelial cell. We have again eNOS generating NO from L-arginine to L-citrulline as a byproduct. And that NO is being used within the cell, some of those chemical mechanisms that I didn't talk to you too much about. It somehow is packaged, and it's going to be released with calcium. And so maybe that's why my grant got funded, because maybe somebody found this paper, but I swear to you, I didn't at the time. And so the SNO can be delivered to smooth muscle cell and cause dilation. And so we've been really working in this space. So this is just to show you that there's some change in permeability with light. I'm looking forward to kind of exploring that here. We've started to try to look and see if, can I take DAF, which kind of we use as an NO-sensitive dye. It indirectly measures NO as a dye. We can see these vesicles contain, you know, a higher percentage of DAF staining. It's interesting though, because I didn't get into the chemistry of this because I'm not that expert, but the auto-oxidation in the N2O3 intermediate to create an S-nitrosothiol is actually, it tends to occur more often in the presence of membranes. And so this may make sense in a vesicle with a lipid membrane. We've been able to show that the multivesicular body has stands for co-localization with LBPA, which identifies the multivesicular body, and again, the SNO cysteine. We also performed some immunogold staining using the SNO cysteine antibody, and we were able to see a lot of punctate labeling, which was significantly increased in the presence of light. So again, there are SNOs in those vesicles. And what I think is really cool is that you can actually see in some of the endothelial cells that transport of vesicles out, which you don't see. And so the electron microscopy has been, was really a nice confirmatory test for at least for us to see it. We also see changes in the size of the multivesicular body and the lysosomes, which is another area that we intend to look at. So from what I can tell you so far, we have a vasodilator in endothelial cells that has the characteristics of an S-nitrosothiol that's packaged within a multivesicular body and is exported, which can cause dilation. So, out of the interest of time, I'll kind of just give you a little bit of where we're starting to take this is down that ROS and oxidative stress pathway. We've been able to see, that we do see increases if we use DHE fluorescence. We have looked at mito-PY1 and starting to look at mitochondrial specific staining for free radicals. This is really in its infancy. As I can tell you, the light must be doing it in a healthy way, because we've seen a lot of positive effects with light, but it still remains quite uncharacterized. But we do know that catalase does interfere with this process. And so if you treat the bath, or if you treat the vessel with catalase and you shine light, you do attenuate the vasodilation, and you do somewhat interfere with the overall dilation. And we've also been able to see in the same methods that we use to kind of characterize with the nanocyte the number of particles and the particle size. What we do see are less vesicles in the catalase and light treated population. And honestly, we've also been able to show that if we go back to the ozone chemiluminescent chamber and try to measure S-nitrosothiols, we do see a significant decrease in the amount of RSNO equivalent. Normally, like I said, I showed you that we're around 4 nanomolar. This gets cut back significantly to around 1. So again, I think there's a lot of opportunity to continue to kind of study what that interaction looks like of how, again, how reactive oxygen species are altering this transport process. So I'm going to finish up with a couple of teasers. I've shown you a lot of chemistry, a lot of physiology, but how does this relate to people? And that's what really I get excited about. So we will start up more experiments like this here at UAB, but we can take human vessels either from adipose tissue or even from coronary artery bypass grafts, in which we can dissect out coronary microvessels. And that's what these are. And you can see that a lot of the responses are similar, but not exact compared to the animals. We do know that this process does appear to be endothelial dependent. And we do know that the presence of L-name to inhibit nitric oxide synthase does not have as great of an effect. So there's a lot to dissect here about really what the relationship is from now adults with coronary artery disease. There are some significant differences there. So I think that's food for thought. And the other thing that we're going to do here is we actually have measured peripheral blood flow using contrast enhanced ultrasound, in which we apply light to the calf muscle and then we measure blood flow. And what you do is you basically pulse with ultrasound. It breaks up all the bubbles, and then you measure the rate of replenishment, which is a really nice way of measuring blood flow. And what we can see here is that the increase there is a hyperemic response after light. That again, it's sustainable within like that 5 to 10 minute range. We've been collecting plasma to measure S-nitrosothiols. There's some variability here. A lot of the work that I'm going to do here is to really further characterize that because it's trending right now as an increase in S-nitrosothiol, but we just don't have the numbers. But what I can tell you is we've moved this into humans. And so Mary McDermott from Northwestern is as a clinical trialist in peripheral artery disease. And she approached me and said, hey, you want to do a clinical trial? And we wrote an R21 and had that one funded. And now another R21 is funded. And basically, the idea is that we will take people with peripheral artery disease and who have a poor 6-minute walk test, and they'll be randomized to either daily red light or sham light. And then we will compare their perfusion based off of a 6-minute walk test. We'll do some muscle biopsy and we'll look at capillary density. And then this is basically what you're seeing is a device where we can regulate the amount of light. I think someday take a SCD that you get in the hospital, just wrap it around your leg, and you can sit and watch television and treat yourself. But we'll do this for 4 months to see if we can really generate more lasting walking, increase our walking distance, and look at some of the histology of the gastrocnemius muscle. And then I'm also working with a tech company to modify one of their laser catheters, which is used for atherectomy, in order to interrupt ischemia reperfusion injury. There's a fair amount of work in ischemia reperfusion injury, and although we get really good at opening up people's clot, there's still quite a bit of plaque and platelet plugs that end up into the myocardium and cause localized areas of ischemia. So we received a grant from this company to study this in pigs in ischemia reperfusion injury. So with that, thank you for spending the last 50 minutes with me so I can explain to you why red light might work as a great therapy. We've seen it work well in mice. As I said, we can see pretty sustained and robust vasodilation. It is NO dependent. It requires a healthy endothelium. And we're really kind of focused on S-nitrosothiols. We're excited to think about where reactive oxygen species and oxidative stress in small or large amounts kind of takes this research. And I think overall, from a translational standpoint, I've given you maybe a little taste of where I'd like to see this work. Obviously, when we think of diabetic wounds and critical limb ischemia, this might be a great step before getting to the point of amputation. So with that, I would like to acknowledge my lab from Wisconsin, Dr. Dorothy Weirach, Agnes Kessler, Brian Lindemer, Grant Brockel, and Leanne Harmon, who helped me with the echo. We had some students, Nick Fabre, and Mike Salinger was a partner of mine who subsequently passed away, but he was like, you really need to do this like in the cath lab. And I'm like, okay. And so we started down this path of developing this catheter. And then I'd like to acknowledge my partner in crime here, Helen Brown, who has the, I guess, maybe unauspicious task of trying to like rein me in and kind of get these experiments off the ground here. So, so thank you all.
Questions now. I guess the first question, so when you get stopped at a red light, does it actually help it lower the blood pressure?
Probably does. I've been asked lasers versus LEDs. We use LED light. So the intensity of light does play a role in some of what we've seen. That is going to be inversely related to the distance. Yeah. So it probably should be. I did the human experiments within like 2 inches. I didn't want it directly on, and you could still see an effect.
Along those same lines, how far do you think this light is penetrating through the skin? And would it be more beneficial the way to deliver that is deeper?
Yeah, so the way that we've modeled it, I don't see, maybe by 2 centimeters, maybe you're getting about 5% of the light intensity. The bulk of it is going to be within the first, half a centimeter of penetration from the skin. As I said, it's not like UV light. We don't have to worry about melanin. However, we've only tested it, I think, in like 2 darker skinned individuals. So that would also kind of play into some of the penetration. I definitely think there's opportunities for looking at ways to penetrate deeper. The plastic surgery group at the medical college, when they saw this, kind of started to work with some bioengineering students to try to think of ways to regenerate nerves along the same, how can we actually deliver it deeper? I also think, and I'll just finish up, the best part of those ex vivo experiments was truly the fact that I have a paracrine factor. And so what we can see is when we're doing our imaging of the muscle bundle itself, I mean, we're talking 4 or 5 centimeters deeper and we're seeing changes in blood flow. So whatever's happening at the surface, it does seem to be enough to get deeper.
Does the type of tissue matter? For example, does adipose tissue, does the light see more deeply or less compared to muscle?
Yeah, so, and we modeled in that way. I think adipose tissue has deeper penetration. Interestingly enough, salons are using it as a liposuction because it actually, when red light hits an adipocyte, it actually almost like punctures a little hole in it and the fat contents come out. There's, like I said, people are all over the map with this, but definitely tissue density. The other thing to think about here is, okay, we have all these chromophores, right? The light is light. It's a physical property. It's going to be absorbed and reflected in various ways.
Are there any publications that you've found that link red light to carcinogenesis or DNA damage?
So no. At the amount of, so photon energy is inversely proportional to the wavelength. And so the photon energy, this was actually something I cared about, one, for the reason. Second thing is that you're like, well, how is then the NO being released? Because, you know, if you're at longer wavelengths, you have more vibration. You don't really have a photolytic cleavage. And so how could I get to this? And actually, I was at an NO Gordon conference and talked to someone who then kind of modeled it out. The photon energy is not enough to photolytically cleave, so then it should not affect DNA. That being said, it's angiogenic, right? You know, so in my mind, maybe the downstream effect is, could this stimulate some cancer tumorigenesis? Because now you're supplying a blood supply, you know, or stimulating more blood flow to a certain area. I've not seen that in the literature, and largely still remains focused on wound healing.
I had a question on the paracrine factor. So CD63, have you proposed or looked at a knockout of that to see if it's required for like these multivesicular bodies or anything?
I would love to do something like that.
And then kind of a follow-up question about when the induction that you were showing with the CD63, is that a like what's the time frame on that? Is that a stabilization of the protein or is that a transcriptional, or do you know yet?
I don't. Yeah.
So if you're targeting patients who already have peripheral vascular disease, do you think their endothelial cells will be able to respond to the same degree that we're seeing in the mice or your healthy subjects?
So I have a lot of hope for that because again, it's not necessarily requiring eNOS to produce the NO source. That being said, eNOS, you know, having eNOS and making NO around is always going to be beneficial. So I don't necessarily believe them to be head-to-head just in the S-nitrosothiols story, where I think it can be more beneficial for those patients, maybe strictly with trying to liberate the NO from iron, nitrosohemoglobin, and myoglobin. That's a great question.
There enough red light and sunlight to have the same effect or a similar effect? Like, do you see this from just like sunlight? Like, what's the natural mechanism that we're exploiting here?
So this is what's really funny because I gave one Nobel laureate. Well, now I'm going to talk about Furchtgott. So Furchtgott is actually, when I started down this, I forget who I was. Farid Murad, the other one who won the Nobel Prize. And I said, yeah, you know, I'm like into light and this, I know. And he goes, you know, Furchtgott would always on his aortic rings lower the shade. And I said, really? And he goes, oh yeah, he got fascinated by this. Go look it up. You know, so again, you go back right into the ages, which is why like there may literally be, no pun intended, nothing new under the sun. So, so if you raised it, he could see the aortic ring dilate, and he actually focused more on the UV and the direct photolytic cleavage of nitrite as his mechanism. So again, light encompasses all wavelengths, specifically to 670, I think it's going to be more of like what I'm saying, maybe a little bit of photolytic, like wobbling, or, you know, finally you can wobble off that NO versus a cleavage of nitrite.
Perfect timing.
All right.
So please join me one more time.
Well, thank you.